Hi, good evening, everyone. Welcome back after a break for Chinese New Year, and 恭喜发财 to everyone. 新年快乐. Today is what day I also given the most count already. But in a few more days, we'll finish Chinese New Year. And I have here with me Dr. Chia, who's my colleague from Sunway. And he, of course, has given us quite a few lectures on rheumatology, him being a rheumatologist, of course. And it's always been very interesting to have him. So I think without further ado, come, Chia, let's start.
Okay, thanks, Betty. Happy Chinese New Year.
Yes.
Okay, let's share the screen. Okay, can you all see the screen?
Cannot yet.
Cannot. Oh, sorry. Okay, this one? Yep, we are. All right, good. All right, good. Okay, so thanks, Betty, for having me here again. So I'm looking forward to some Ninko. Okay.
I have to bribe him, to have him here. Yes, yes.
For Ninko, it's actually a good bribe. Today, I'm going to talk about one of the common rheumatological condition that we see in the clinic. And the interesting part about this disease is that it's also being actually co-managed widely by other colleagues, particularly the dermatologists, even and as well as the primary care. So today we are talking about psoriatic arthritis or PSAs. So today's content will start off with some introduction and a case presentation that I would like to share. Talk a bit about the pathogenesis and pathophysiology, clinical features, principle of management, assessment, treatment, and summary. Not too much of detail on that. Okay, so start off with a case that I actually saw this patient when I first joined Sunway a few years back. Yeah, so he is a 45-year-old Indian gentleman working as a cab driver. So he was from one of the town in up north actually. So he came to me because he has been plagued with a chronic pain at multiple sites for the past 2 years, and all these painful symptoms over the both legs and hands, with one episode of right knee swelling that he could recall. He has sought treatment from various doctors, treated with oral NSAIDs, but the symptoms never really resolved. And what happened was that the pain actually got worse, and it started to get into over his right heel, and so because of that, he couldn't drive as before. So this will be a so-called homunculus of his joint presentation. So the red spots are the tender and swollen joints, while the blue spots are the tender point whereby it's outside the joint. So we call it as enthesis. And you notice the yellow color sausage-like toe over there is actually showing the whole so-called left second toe it was actually swollen like sausage. So if you look at the back of his heel on the right side, I mean, trust me, it is swollen, yeah. And when you examine him, of course, being a rheumatologist, we already smell something fishy. So we look through his scalp. We look through his scalp. We look through his stomach. We look through his buttock. He was quite amazed why I have to actually flip through his underwear, and look at his toes.
So the skin lesion may not be very obvious, lah.
Yeah, that is the point here I would like to share.
Mm.
So, in fact, he has been self-diagnosed with scalp dandruff since the early 20s. And interestingly, his younger brother also has similar chronic skin problem. Okay, so the initial blood test from his own local lab showed elevated ESR and CRP, uric acid was high, but rheumatoid factor was negative. So initially he was thought to have gout, but definitely that's not the problem. So we proceeded with musculoskeletal ultrasound that we did in our clinic. So what we can see here is the first image showed this is the longitudinal view of the Achilles tendon is swollen. The red spots there are all evidence of inflammation. Yeah. And you look at the so-called calcaneal surface is irregular. So mean to say that there is element of Achilles tendinitis and it's actually causing destruction or this to the so-called the calcaneum bone. Okay.
Sorry,
And
can I
look at
ask you, when you do
yes,
ultrasound in your clinic,
yes.
that the red color, is it color Doppler or is it the
We use power Doppler. We don't use color Doppler like you all, yeah,
that's right.
because
It's called what?
sorry?
It's called power Doppler.
Power Doppler, PD signal, yeah. So
See,
color Doppler will differentiate between arterial and venous flow, ma. This is the
yeah.
blue and the, but power Doppler is just basically if there's increased blood flow, yeah.
Okay.
So the toes also show evidence of arthritis and the synovitis at the so-called the proximal interphalangeal joint. And when I scan through the whole second toe, so there was a so-called continuous inflammation or swelling of the so-called the tendon. So that gives rise to this sort of sausage toe feature. Okay, so of course, this is psoriatic arthritis, yeah, because the scalp is actually scalp psoriasis has been there for over 20 years, and then subsequently he started to develop psoriatic arthritis. So what is psoriatic arthritis? It's known to be seronegative because the old teaching taught us that it should be seronegative, meaning to say the rheumatoid factor should be negative, but in real life, there is some percentage of patients who will have a bit of a mild positive RF. So don't get so-called don't taken aback if let's say you notice some mild positive RF. So it's a chronic and inflammatory arthritis, which is in association with skin psoriasis. Yeah. So usually the RF is negative and the anti-CCP is definitely negative because as we know, anti-CCP is more specific to point towards rheumatoid arthritis. And PSA is actually classified as one type of the subtype of spondyloarthropathy. So this is a bit confusing to non-rheumatologists. So what is spondyloarthritis? Basically, if you look at the so-called the graph at the right-hand side, this is actually a big umbrella of the term that cover the so-called the different spectrum of diseases. We share the similar feature. They will have enthesitis, dactylitis, iritis, peripheral arthritis, as well as spondylitis. And commonly, they are closely associated with HLA-B27 positivity. So as you can see, under the SPA, you have angstpon, you have psoriatic arthritis, you have IBD, you have reactive arthritis, and you have those undifferentiated left, right, and center. So all these are actually under the same umbrella term. So PSA, how common is it? Actually, male to female ratio is almost the same. And what is so important about PSO is that we all realize that PSO is actually a precursor of future development of PSA. So 1 in 4 patients with PSO will eventually develop PSA. Okay, and among those severe psoriatic skin psoriasis patient whereby the so-called the body surface area is more than 10%, out of 25% of them will eventually develop PSA. Yeah.
O means what? O?
Oh, sorry. PSO means skin psoriasis. PSA is psoriatic arthritis.
Okay.
Sorry, my bad.
Okay.
So how soon the PSO how soon the arthritis can happen? Actually, it can average around 7 to 8 years, but actually there were cases of 10 to 15 or even up to 20 years. Yeah. And commonly, almost 80% of the patient who started with skin psoriasis first for umpteen years, only then develop the arthritis. The remaining 10% will be either both to happen together or the arthritis will come first, then after that, only develop skin psoriasis. Yeah. Okay, so main feature of psoriatic arthritis, as we mentioned just now, is a very diverse so-called feature. So apart from joint involvement like distal interphalangeal joint, you have nail changes as well, ranging from nail pitting to dystrophy. You have enthesopathy. Remember the Achilles tendon? Yeah, it's one of the hallmark feature that the so-called rheumatoid arthritis will never have. Dactylitis is also relatively very specific towards this condition. And to make things worse, back involvement. So chronic inflammatory back pain can also present in psoriatic arthritis. Okay. So and that all with the background of skin involvement, meaning to say that the patient usually will have evidence of skin psoriasis. Okay, again, this is to show diverse clinical features of PSA from peripheral joint to axial joint to the antisil point to the sausage finger or sausage toe and then skin and the nail. Okay, skin psoriasis is common. It's very common among the primary care and most of the time it's easily identified. Okay, so over the scalp, over the extensor surface like over the knee or elbow and over the hands. But in real life, life may not be that simple lah, like what you mentioned just now, Betty. So the skin psoriasis can be very subtle, can be at a very hidden area, can be at the
Okay, you have to
around.
change slide because I scared kena.
Really?
Okay.
Yeah. Oh,
Yeah.
okay.
Okay.
Can
I'm
be.
so scared.
Oh no, this is another buttock. So how?
Cannot.
So different type of psoriasis will actually have a different risk of psoriatic arthritis. For example, if you have nail psoriasis, the chances of
Okay,
psoriatic
you
arthritis.
have to change.
Okay, change.
I'm so scared. Okay.
Okay, so this one, psoriatic. What
You
happened to
know,
our
I get
country?
distracted, my whole page get banned.
Oh, okay.
Sorry.
So, psoriatic phenotype associated with increased risk of PSA are this one without the gamba. So if your scalp psoriasis is almost 3.7 times of higher chance of developing arthritis, nail psoriasis 2.5%, 2.5 times. If you have inverse psoriasis, those at the so-called the gluteal fold, yeah, almost 2 times. And what other major risk factor? If you have first degree relative of PSA, then there's up to 40% of you who will develop psoriatic arthritis, severe psoriasis that mentioned up to 25%, obesity, yeah, and then subclinical musculoskeletal inflammation and serum biomarker. These are the other major risk factor.
Okay, sorry, can you go back to just previous slide?
This one only.
Yes, it's right. So sorry. I need
No
to
worry.
explain a little bit to everyone.
Yeah.
Okay, because of our webinars, right? And a lot of times we have to have slides of demonstration of lesions, wound. My Facebook has been restricted many times because they say that it's graphic, it is violent, it is nudity. So I'm so restricted that my number of days of restriction have increased from 3 days, now it's 30 days. So I'm scared that my page will get blocked.
Okay,
Coming
understood.
back, when you have PSA, which are all seronegative, right?
Correct.
Are you also increase in risk of getting seropositive kind of arthritis?
No.
No. So there are two different.
There are two different entities altogether.
I see.
So far, I've only remembered one patient along my years of practice, whereby the patient has rheumatoid arthritis and skin psoriasis, which to me is a rare breed lah. Because
so how do you then differentiate that her arthritis is rheumatoid and not psoriatic arthritis?
Good question.
Yes.
Because it was labeled by my senior, so I just follow lah.
Oh, I see.
That was many years ago.
I see. So it may not lah. You're not sure.
No. I think to be fair, that time I remember the patient was seropositive and the rheumatoid factor was very high. So we can't disregard that part lah. Then I remember now. Yeah.
Okay. Okay.
Okay. So can we continue?
Yeah. Can.
Okay. Good. Okay. This one no nudity. So transition from psoriasis to PSA. Why is it important now to pick up psoriasis? Because we now believe that seems to show that evidence have shown that psoriasis is actually a precursor of future development of psoriatic arthritis. So why? Because there is underlying so-called interaction of aberrancy in the immune system that involves a lot of different cytokines, inflammatory cytokines, so-called IL-17, IL-23, TNF. So that's all advancement in the so-called knowing the pathogenesis of psoriasis that will also lead to so-called the development of newer generation of drugs such as which are biologic agent. So psoriasis, when there is a so-called activation of this aberrant immune system, and the activation can come from either from the skin, the skin psoriasis, or the gut, So that's why inflammatory bowel disease such as Crohn's and ulcerative colitis also belong to the same category. And another thing is enthesitis. So this is one thing that actually which is very fascinating about psoriatic arthritis. Biomechanical stress injury to the tendon or even ligament in a person who is genetically susceptible can trigger off this cascade of inflammation. I have one middle-aged gentleman who actually started off with a twist over the ankle while playing football. Then guess what? When it started off with just a twist over the ankle, then after that, within a couple of weeks, he developed full-blown multiple joint pain and swelling.
I see. And
Mm.
this enthesitis, I never heard that term in my whole entire medical career. What does it
Oh, okay. Enthesitis is referring to the site of enthesil which is inflamed. What is enthesil? Enthesil is a part of the is a part whereby the so-called the tendon is attached to the bone. Remember
Oh, I
golfer's
see.
elbow and tennis elbow?
Uh-huh.
Golfer's
So why
elbow.
not use tendinitis instead of enthesitis?
No, because it's a very specific term to denote the site of the inflammation, which is at the attachment of the tendon at the bone. Yes.
Oh, okay, okay.
So like for example, Achilles, for the at the tail end of the Achilles, which is attached to the calcaneum, that is a common enthesil point. Your medial and lateral epicondyle over the elbow, these are the enthesil site.
So how do you explain that the first presentation can be, let's say, an inflammation of a tendon?
Yeah. I mean, that's what I'm trying to say there. Because in a genetically susceptible person, especially if let's say the person has HLA-B27 positive, so if he or she injured his tendon, particularly at the enthesil site, so that will actually drive the so-called inflammatory cascade to release all these inflammatory cytokine. So this is something fascinating about psoriatic arthritis, which will not happen in rheumatoid arthritis. A physical injury can trigger the psoriatic arthritis or trigger this type of arthritis.
Oh, very interesting.
Very interesting. We had quite a number of patients admitted. Otherwise, I mean, investigate left, right, and center. Then turn out that this patient has HLA-B27 positive, and they responded very well after they are given biologic agent. Then they went straight into remission.
But let's say a wound is also will cause inflammation, right?
Correct.
But
the wound over the skin in a person who is genetically susceptible, the word must be genetically susceptible. You and I, if I get the wound, if you have don't have such genetic compound, we will not get this problem. Yeah.
So a wound also will also trigger this cascade.
Correct.
Oh. So do you see a lot more after the COVID? COVID also has a lot of
yes, I mean we do see cases whereby the so-called the onset of psoriatic arthritis happen after they got COVID or they recovered from COVID. But with the background of most of them with the background of some chronic skin psoriasis, but it's relatively stable. Yes.
Interesting. Okay, go on.
Yeah. So from the psoriasis, then it proceeds to preclinical, subclinical psoriatic arthritis, whereby there's no pain, but if you do the ultrasound, you see some evidence of inflammation, and then arthralgia and fatigue will set in, and then only then goes to classifiable PSA. Yeah. So this duration from psoriasis to psoriatic arthritis may take up to 20 years, 15 to 20 years to develop. So the current concept is that if you can identify those skin psoriasis category patients which are regarded as a high-risk category, and you start to treat them effectively in terms of their psoriasis, you may be able to halt the progress of the psoriasis developing into psoriatic arthritis. So this one, we really need whoever treating skin psoriasis personnel, be it a primary care dermatologist, to understand the concept.
Oh, especially primary care, right? Because
yes,
they see.
Yeah. So this cartoon is just to again to highlight the how actually psoriatic so all these PSAs or spondyloarthritis can develop. So gut, HLA-B27, and another one, biochemical stress, particularly if you have the biochemical stress at the enthesil point, then you upregulate the production of all the inflammatory cytokine started forth with IL-23, then you activate the other IL-22, 17, TNF, then all this will lead to all the cascade inflammation, bone loss, bone proliferation, and then psoriasis. So it's a process that starts from one end, then progress to the other end. Yeah.
Oh, I
Okay.
didn't know can cause ankylosing
Yes,
spondylitis.
it does. Okay, so how bad is psoriatic arthritis? It's bad because it's an inflammatory arthritis, so it does actually cause progressive joint erosion or damage and erosion, which is irreversible. Okay, if left untreated, they will lead to limitation and disability. Okay, so look at this diagram. As PSA progresses, the disease will get more severe and the mortality will also increase. It will take around 10 years for at least one erosion to happen. Then by 20 years, at least we'll have more than 5 deformed joints. And towards the end of their life, they will get a lot of this severe pain, disability, and then because of all this ongoing inflammation and the so-called suboptimal treatment or overusage of NSAIDs, they will lead to increased risk of CVD. Then they will go to you, Betty.
Cardiovascular disease.
Yes.
I see.
Yes.
I've
Yes.
never actually. Okay, I have one patient who has psoriasis. Not psoriatic arthritis, but
Okay.
psoriasis, but very, very widespread psoriasis. And
Yes.
he too had coronary artery disease
Yes.
in his 40s.
Yes. Compared to rheumatoid arthritis, psoriatic disease, whether with psoriatic arthritis or without psoriatic arthritis, they tend to be highly associated with metabolic syndrome. Okay, namely high lipid, high sugar, high blood pressure, fatty liver, more still if they are obese, yeah, and then and gout, yeah. Okay, so the challenges sometimes when we deal with these patients is that when the patient has acute joint attack, and it's just a one-off first presentation, we are not sure whether the patient is having acute gout or it's because of the so-called development of a psoriatic arthritis flare. So these are patients we need to actually continue to follow up and monitor, see the trend of the so-called arthritis. Because as we all know, gout normally happen one-off, then after that it subsides quickly and then come back again. As compared to psoriatic arthritis, it tends to be persistent. Okay, so this is what we still use as a classification criteria to classify psoriatic arthritis, called Casper criteria. So it's a very simple scoring system. So in order to score, the patient has PSA, so they must have evidence of either current psoriasis or personal history of previous psoriasis or family history of psoriasis. And then when you examine the patient, if let's say they have new changes from dystrophy, pitting, hyperkeratosis, you score. Rheumatoid factor negativity will score. Dactylitis definitely will score. And radiological evidence, it shows juxta-articular new. Okay, this one is a bit complicated because the X-ray changes in psoriatic arthritis is different from rheumatoid arthritis. In X-ray changes in psoriatic arthritis, what happens is that there is this new bone formation just beside the joint, whereby in rheumatoid arthritis is periarticular erosion or osteopenia. So there's a bit of difference. This one need not to dwell in detail, yeah. So diagnosis of PSA require history, like mentioned, swelling of the joints, spinal inflammation, and you must have features of inflammatory arthritis, which is morning stiffness, tenderness, and swelling, and of course, impact functional capacity. Okay, now, this is just a fun part. So there are a lot of different so-called presentation on the joint in PSA. So what do you think is the commonest pattern of joint involvement? Number one, is it asymmetrical oligoarticular, mean to say that just one joint or two joints, but they are not symmetrical. Number two, symmetrical polyarticular, something like rheumatoid arthritis, both sides. Number three, arthritis mutilans, the so-called the complete deformity of the joint. Number four, distal interphalangeal joint. Or number five, axial joint, which is a spine. So have a wild guess maybe.
What is that? What is the commonest? Okay, guys, come with question. What is the commonest pattern of joint involvement in PSA? Asymmetrical
oligoarticular, meaning to say that it's just one or two joint, but it's asymmetry.
Okay, we have Dr. Tan saying is D. Somebody says A. With no name. A is D is predominant DIP joint.
Distal interphalangeal.
Oh, that one is rheumatoid arthritis, I think.
No.
No. Okay, okay. I myself don't know. Okay, I'm just guessing. Dr.
Ah.
Dungeon said D.
Ah.
A lot of D's, huh?
These are,
A.
okay, this is textbook, but in real picture, many
Uh-huh.
of them are actually symmetrical polyarticular, something like rheumatoid
Oh,
arthritis.
nobody
So,
said B. Okay.
yeah, sometimes it can be very challenging, okay? But one thing that will differentiate RA from PSA is that, remember, RA will never involve DIP.
Never. Oh my
Never.
God.
Now,
Distal interphalangeal.
yes,
Tell me which
the
one.
little pinky, the distal joint, yeah, the
The
distal
distal joint.
interphalangeal.
Usually the first one, is it?
It usually will be the RA will be the MCP, metacarpophalangeal, and proximal interphalangeal.
Oh, so never the distal.
Yeah. Okay, so that is RA. But again, in real life, the commonest features of joint involvement in PSA is also symmetrical polyarticular. Okay, but it can involve DIP joint, which is never in RA. Another thing to try to differentiate is that apart from this, in RA they will never have enthesitis. Yeah, remember that they will never have dactylitis as well, the sausage finger or sausage toe. So these are the clear-cut features
Can
that
I
differentiate.
ask you, how is it like, let's say in RA, the immune is abnormal immunity to certain joint particles, protein, right? Why can they differentiate the DIP and the PIP?
Wow, this is a Nobel question. We wait for anyone who get Nobel Prize, they will know
How
that.
can the immune system differentiate the DIP from the PIP? You say will never.
Yeah, will never.
Will never. No, will never means by the time the inflammation reach the PIP, they will say, okay, don't go to the DIP. Why? I don't know. Just don't go to.
I have no answer for you as well.
Okay.
But just remember this lah.
Okay. So for all the MRCP students or medical students, rheumatoid arthritis do not involve PIP. Okay, go on.
Okay, so again, the commonest subtype, polyarticular. Yeah, the key difference between RA and PSA is DIP involvement. Okay. Peripheral joint involvement. Okay, this is arthritis mutilans, whereby it's very easy to identify from clinical feature, but fortunately it's not common. It's less than 5%, because it will give rise to the kind of a telescoping of your joint, because the terminal absorption, and then the thing will get actually shrunk back. So which in the X-ray you can see the bone is actually gone, which is very horrible. Yeah. So in the X-ray of the established PSA, you have a lot of features that you can see: mutilans, dactylitis. Yeah, this is a normal joint. Yeah. Okay. Synovitis. So and remember I mentioned just now the so-called osteoproliferation, outgrowing of the bone. So it happens in psoriatic arthritis, but not in rheumatoid arthritis. Yeah.
Can you explain to me dactylitis?
Dactylitis is a term to describe so-called generalized swelling of the digit, either toe or
the
fingers.
sausage one.
Sausage fingers or sausage toe. Yes.
And is it the bone? Does the bone get inflamed?
No, it's actually the whole soft tissue along the so-called the tendons that actually go along the so-called the toes or the finger.
Oh, okay. Interesting, huh?
Okay, so this is dactylitis. As mentioned, you look at the second finger, and enthesitis, like I mentioned just now, at the heel there. So it's happened among up to 50% of the patient. Yeah. So how do we actually use radiographic examination to help to diagnose PSA? X-ray, unfortunately, is not that sensitive unless the image, this already established structural damage. And of course, this is not an ideal situation. MRI is a good modality, but the problem is, as we know, it's expensive, it's not easily available. So that's why we are relying more and more on ultrasound sonography, or musculoskeletal ultrasound, because they can detect and evaluate inflammatory activity. Okay, and it's relatively inexpensive, but the thing is operator and machine dependent. Yeah, so you must have person who can do musculoskeletal ultrasound, and you must have a relatively decent standard of ultrasound machine in order to perform a good musculoskeletal ultrasound. Okay, so joint damage, as mentioned just now, okay, joint destruction, you see the one with the white arrow, you notice this bone proliferation. Yeah, this is what we mentioned. Yeah, so that's why we always emphasize early diagnosis is treatment really plays a very important role, because once the damage is already established, nothing much we can do to reverse it. There's no way of reversing whatever is damaged. Yeah. I mean, to make life more complicated, like I mentioned from the beginning, psoriatic arthritis can also involve the spine. So they may have inflammatory back pain. So again, X-ray will be a crude modality, but it's always as a first line because it's cost effective. You look at the sacroiliac joint to look at evidence of sacroiliitis. But unfortunately, if you can detect sacroiliitis from X-ray, mean to say that there's already established structural damage. Same thing goes to the syndesmophyte along the so-called spine. So these are already established. So the gold standard or the ideal standard will be using MRI, because MRI can pick up inflammatory signal, bone marrow edema, without waiting for the structural damage to happen. Ultrasound is useful in establishing enthesitis. As mentioned just now, remember that this is the lateral epicondyle of the elbow. So when you do the ultrasound, you can see the area there is swollen and inflamed. Okay, dactylitis as well. The whole tendon is actually swollen and inflamed. Okay, so this is the role of ultrasound, which cannot be picked up by X-ray. Again, this is ultrasound showing Achilles tendinitis and radiocalcaneal bursitis. This is one of my earliest patients. Yeah, the
So this
ultrasound.
ultrasound is in your room. You can do it anytime. Or you have to
It's
send it to
available in my,
radiologist.
it's available in my room. So that's why we can
Also,
do
you don't need to send it to the radiologist.
No need, because we are trained to do musculoskeletal ultrasound in rheumatology. Yeah.
I see. You're trained to do that. Okay.
Okay, so PSA until now, there's a lot of unmet needs. Why? Because it's always often underdiagnosed or misdiagnosed. Number two, there's still some lack of awareness of PSA, even among patients and healthcare workers. And there's no standardized screening tool. Okay, and the criteria of rheumatologist referral is still very gray. Yeah, because you can land in different specialty, dermatologists, orthopedics, yeah, or even spine surgeon, yeah, spine orthopedic or spine surgeon. Only then they will cross-refer to us. Yes. So diagnostic marker do not exist. There's no such thing as a marker to diagnose or rule out psoriatic arthritis. ESR and CRPs are helpful, but just to take note that do not rule out or brush off any evidence of psoriatic arthritis or inflammatory arthritis patient, because it's only elevated among around 50% of the patient. Yeah. So same thing goes to ankylosing spondylitis. Many patients with ankylosing spondylitis in the early stage, their ESR and CRP are normal. Yeah. So, and they are seronegative for rheumatoid factor and HLA-B27 positive, even though we say that it is close, it belongs to this genetic so-called group. But if let's say the patient only has peripheral joint involvement, it's only positive around 15%. Okay, look at this one. If you have ankylosing spondylitis, up to 90% of the time when you check their blood, they are HLA-B27 positive. But if you look at psoriatic arthritis, if they are only involving the peripheral joint, it's only positive at around 15%. So to be honest, HLA-B27, because of the cost, may not be the best screening, it may not be an ideal screening tool or investigation tool for patients with PSA.
How much is it?
Oh, wow. It's almost around 600 ringgit now.
Okay, and then where do you send it to?
I mean now Sunway we have run
Oh, I see.
in-house already. Last time we used to send out, it would take 3 weeks, but now Sunway has the lab has done it, is doing it themselves, so it will take around 1 week only.
I see.
But it's around 600 ringgit.
Okay.
Okay, so and take note that PSA symptoms may also overlap with other condition. For example, you can actually get same problem with diagnosis like gout. You can same or osteoarthritis, yeah, or even rheumatoid arthritis, such as stiffness, peripheral joint involvement, and so on. Okay.
Sorry, can you go back to the previous slide? So this dactylitis and enthesitis, they are not pathognomonic of PSA lah.
Not 100% yes, because like what you can see here is that it can happen in gout, no? Gout because of the crystal arthritis, sometimes the whole finger or whole toe is swollen. So it's a bit difficult to differentiate at a glance. Yeah, you need to have.
So can I ask you the next question? Sorry, this dactylitis, right? In PSA, you do an ultrasound, you see inflammation along the tendon.
Yeah.
But in gout, you won't see the inflammation along the tendon, right?
You may
also.
Because especially chronic tophaceous gout, because the tophi deposits along the tendon, you may.
I see. Okay, I'm learning quite a lot here. Okay.
Okay. So again, okay, what is the outcome of delayed diagnosis? So poorer long-term outcome, more erosions, more deformed joints, chances of developing sacroiliitis, deformed joint arthritis mutilans, and the most important thing I think all of us are interested in is drug-free remission. What are the odds that we can actually get the patient out from the treatment in the future? So if you delay the diagnosis for beyond 6 months, you see the so-called drug-free remission will drop at least to up to, I mean, more than half of the chance. Okay, this is just another way to elicit the point here. So the window of opportunity is to achieve drug-free remission. You treat from the beginning in order to get a very effective or aggressive control and bring the disease into remission. So if you delay the diagnosis for beyond 1 year, the chances of drug-free remission is almost none, to be honest. Wow. But if you can treat from the diagnosis to treatment within 6 months, your drug-free remission chance will be highest. So must again emphasize the importance of early diagnosis and early effective treatment. Okay, so up to 20% of adults will seek help from the primary care or GP. So GP or primary care plays a very important role. So which screening questionnaires will be most useful for PSA? There are quite a number. So this is one of the recommendations. As early as easy as PSA, pain in the joint. Ask whether the patient has any painful joint or antisil point. Remember the enthesitis there. Stiffness, which lasts more than 30 seconds. Swelling is a hallmark feature. Then axial, look at the back pain. Okay, so if let's say any of the 2 or the 3 components are present, then go to the proper screening tool. There are a lot of screening resources available, but we tend to stick to this one, PST, yeah, which is psoriatic epidemiology screening tool, which we find it more feasible. So basically, just to answer question, ask the patient to answer any swollen joint, yes or no. The doctor told you that you have arthritis, fingernail, toenails, or with pits, pain over the heel. Okay, so the whole finger or the toe swollen for no reason, then you start to click the site where the patient detect any pain or swelling. Okay, so this will be a good tool to actually to assess to assess the possibility of PSA. If any 3 and above is positive, please refer to your rheumatologist.
Is psoriasis a need for the diagnosis? Can patients have psoriatic arthritis without psoriasis?
Okay, I mean, most of the time, yes, because you remember around 80%, at least 80% of the patients will have existing skin
yeah, that's
psoriasis
right.
before they develop PSA.
Yes.
But like what you said just now in the beginning,
Oh,
Betty,
yes,
there
7%.
were patients who didn't even know that he or she had psoriasis.
Yes, but they do. They thought that they have scalp problem or something.
Correct,
But
correct,
are there anyone? I think I saw a 7% that
correct,
present with psoriasis.
correct. There will be
arthritis
another
first.
10%, around 10% whereby the joint will start first, only then the skin will develop. Yes, I do have one patient like this. And there's another one that joint and skin happen together.
Oh, okay. Because I have a Facebook friend that from overseas that has been having severe, arthritis. And first they thought it was ankylosing spondylitis, but now he has pain elsewhere and they have not gotten a diagnosis yet. But he never mentioned he has skin lesion. So he could be having okay, go on. Okay.
Okay, so for any patient with chronic back pain, which lasts more than 5 months, this is another simple inflammatory back pain assessment. Yeah. So so basically is to ask whether your age of onset, the pain develop gradually, the pain improve with exercise, no improvement when you rest, or suffer back pain at night that wakes you up. So if the person score 4 and above, then likelihood the patient has inflammatory back pain, and please refer to us as well.
So does your back pain improve with exercise? So your back pain actually improve with exercise?
Yes, because inflammatory back pains are mainly resting back pain. When they rest, when they sleep at night, after they are not moving, prolonged immobilization, the pain will become more severe, and sometimes it can tend to wake them up in the middle of the night. And then when they wake up in the morning, they feel that the back or the buttock area is very stiff.
Oh,
and then when start to move around, they feel better.
Okay.
Okay, so so this will be a so-called a guideline on how to actually manage psoriatic arthritis. So basically, we have to assess the phenotype. So skin ka, axial ka, peripheral ka, enthesitis or dactylitis. Then these are the tests that we do from imaging to the bloods, yeah. And then remember, we also have to assess the comorbidity, cardiometabolic condition, and then the so-called the risk, the so-called the poor prognostic factor such as erosive marker, erosive imaging, and something like that. And then start treatment and monitor. Okay, so this is just a rough idea on what are the treatments available for PSA. Basically, these are DMARDs, disease-modifying anti-rheumatic drugs, just like your RA. Okay, so in terms of non-pharmacological, they have to emphasize on physiotherapy to strengthen the muscle, occupational therapy. Smoking cessation is very important because smoking can actually increase the cardiometabolic risk, which is already there among the psoriatic arthritis patient. Okay, smoking also can worsen the disease activity. Yeah, weight loss is also one of the important factors because obesity is closely associated with poor disease control. Okay, symptomatic treatment, usually the guideline says that we will start off with NSAIDs plus minus steroid, but remember, in a patient with established skin psoriasis, we don't advocate using oral steroid continuously because the exposure to systemic steroid will lead to worsening of your skin psoriasis. Okay, NSAID is to buy time as a bridging therapy. Then you must start off with DMARDs. DMARDs, we have the conventional synthetic DMARD, like the one that we use for rheumatoid arthritis. Methotrexate is good for the joint and skin. Sulfasalazine is good for the joint but not skin. Cyclosporine is for the skin, not joint. Leflunomide for the joint. Apremilase is for the skin. Then followed by the range of anti-TNFs. Biologics, sorry. Start off with TNF, or we have TNF inhibitor, IL-12, 23, IL-17, and even JAK inhibitor. So these are the advancement of psoriatic arthritis treatment. Okay, so the problem with conventional synthetic DMARDs, even though it's cost-effective, is cheapest. But to be honest, they are actually not very proven in terms of their efficacy in PSA. This is basically just mainly extrapolation from the treatment from rheumatoid arthritis. Yeah.
I see.
So, but in real life, unfortunately, like it or not, we still start this conventional synthetic DMARD because the reason being very clear, cost issue. Yeah. And there are some mild form of psoriasis or psoriatic arthritis patients do respond to methotrexate or sulfasalazine. So it's not harmful to give a try. Okay, so what are the treatment target? So remember all this chart, all the IL, the inflammatory cytokines which are involved. So biologics are targeted against this. It's a very targeted targeting the specific inflammatory marker in order to halt or to control the disease. Okay, so but again, not all biologics or not all treatment modality will cover all the components. So you have all these domain that you need to look into. For example, if it's just pure peripheral arthritis, you can use a lot of things. But if it's axial, the one in orange, you notice that anti-TNF works well, IL-17 works well, JAK inhibitor can work, but IL-12, 23 doesn't work, you see? And the conventional DMARD, like for example, methotrexate, sulfasalazine, do not work, will never work on axial. So it's not worth trying at all. Yeah, in fact, it causes more side effect toxicity. Yeah, so the interesting part about psoriatic arthritis, or I would say the challenging part as compared to rheumatoid arthritis, because you have a lot of domains to take care of. So you need to see what sort of patient domain they have, and then in order to choose the most suitable treatment option. Okay, then don't forget about the comorbidity. Okay, so like we mentioned, the patient, they are at risk of cardiovascular or cardiometabolic diseases. Like for example, obesity lah, fatty liver lah, heart failure lah. So there are certain things that we need to avoid. For example, if the patient has established heart failure of NYHA class 3 and beyond, TNF inhibitor is out. Yeah, if the patient has, patient has fatty liver, honestly speaking, methotrexate is not the ideal option. But in real life, unfortunately, we will still use methotrexate with close monitoring. Okay, so now let's talk a bit about biologic. What is the value of biologic here? Biologic has been proven to be able to actually mitigate or halt the progression of psoriasis to psoriatic arthritis. This chart is just to show in a patient who is being treated with UV light for skin psoriasis as compared to biologic. So over follow-up, less patient or that on biologic will develop psoriatic arthritis over the years. And this is our treatment target. What are we trying to aim for when we treat patients with psoriatic arthritis? This is from the group called GRAPPA, which is specialized in this psoriatic arthritis disease. Okay, so basically we are aiming for minimal disease activity. So what are the minimal disease activity? 5 out of 7 criteria should be met. These are the things. But in real life, actually, it's quite challenging. This is just one of my last slide. So remember just now, we said there are a lot of domains to take care of: arthritis, axial, enthesitis. So this guideline actually makes our life easy by telling us or advising us what sort of treatment will be the best option when you are dealing with the different domain. So this one is actually available online. Okay, but of course, in the end of the day, you have to discuss with your patient, because all treatment does have its issue of safety, okay, efficacy, route administration, but I think we also have to take note on, which is a very factual thing, cost, okay, because there's no point of introducing something that the patient cannot sustain. Yeah, sustainability is very important. So cost plays an important role, and patient preference. And in the end of the day, we have to have a shared decision making. So what we and patient agree upon on the treatment that we like to start on the patient may not be the ideal one, but at least it's something that both doctors and patient agree upon. I think that will be my last slide. Yeah.
Okay. Any questions, please? Anyone at all? Doesn't matter, from Facebook, Docquity, or from Zoom. I want to ask, what are the chances? I mean, how many % of patients actually go into remission and actually become medication free? And how long will this period last?
Good question.
Everything I ask is a good question.
Yeah, good question. Because honestly speaking, the so-called there's no so-called data to show what are the so-called the percentage of a patient treated will develop drug-free remission. But generally speaking, the idea is to keep the patient in a sustained remission state. Sustained remission state, by definition, is also being borrowed from rheumatoid arthritis, whereby continuous remission for beyond 2 years. Once you are reaching beyond 2 years, and then there's a high chance that the patient can actually taper down the medication or eventually goes into drug-free. But I don't have the answer for you, sorry.
Okay. So Dr. Gajan from Doquity asked, what is the cutoff point of referral when using Casper?
Oh, what is the cutoff point? If let's say you have actually anything, if I'm not wrong, it's 3 and a score 3 and above, if I'm not wrong. Yeah, you can refer to the so-called the Casper guideline. Yeah.
Okay. Any more questions? Anyone? So, okay, for all the nurses, I've already sent out the registration form, and then for the doctors, the CPD form is there because we don't have any more QR code. MMA has banned that. And oh my God, sorry, my dog is, oh, sorry, hold on, my dog. Okay, Dr. Ravi asked, is there a stage of reversible damage? Oh my God, Houston, hold on, Houston, sorry, hold on, okay, sorry, okay, any reversible damage, any stage, is there a stage of reversible damage?
Oh, okay. If you define damage, once there's already established damage, is not reversible. When we define damage is when there's already a structural changes, and when these structural changes is already apparent, unfortunately, is irreversible.
So basically, if arthritis, inflammation, it is still reversible, right?
Correct.
And
Once you allow the arthritis or the inflammation to progress until it starts to develop structural changes, then it's not reversible.
Okay. Any more questions? Okay. If no more questions, we will end here. And then don't worry, we're going to have another session with Dr. Chia on ankylosing spondylosis.
Spondylitis, yeah. Oh,
spondylitis, yes. Okay, Dr. Radha asked POA affecting the knee joint. What's the percentage like?
Oh, I mean, if psoriatic arthritis affecting the knee, I think is actually still based on the so-called the oligoarticular. Oligoarticular meaning to say that is an asymmetrical oligoarticular subtype. So is
Now we can go back to the
30%.
slide if you want.
Yes,
Yeah.
correct.
Yes. Attendance form for that I've already shared. Hey, where is it now? How come don't have? They're here. Okay, for doctors, is this one, yeah? Okay, there you go. Okay. Anyone having problem, please just message me. If not, enjoy the rest of your evening and Kong Si Fa Chai again.
Yeah, happy Chap Kome.
Happy Chap Kome. And I see you next week. I can't remember. But see you. Bye, Chia. See you tomorrow.
Bye. Good. Yeah.
Tomorrow I buy for you the nin.
I'm waiting for that.
Okay, see you.
Bye.
I buy, but you never come.
Bye.
Because you're so busy with your clinic. My clinic,
sad.
Getting busier and busier again after Chinese New Year.
Agree.
My clinic never reduced in numbers, during Chinese New Year.
Wow. Okay, I'll see you. Bye-bye.
Bye-bye.